And finally, which partnerships could your patients benefit from most? So these are just some questions to sort of put in the back of your head as we get started here. We'll come back to this stuff in a little bit. But I'm going to go ahead and get us moving here. So thank you so much to everyone who has been able to take time out of very busy days to join us. And we're so excited in just a moment to be able to introduce to you Wendell and Jerry. We're going to be talking about coordinating call, the coordinating care theme, and Jerry and Wendell will be presenting some of the work that's being done in the Menominee area. And then finally, we'll come back to some of these questions, and we really are hoping that everyone will get a chance to participate since we've got a relatively small group. So really quick reminders, just to give you a sense, remembering our sort of toolkit themes, we're set in the coordinate area. So I'm not going to spend a lot of time going through these slides. I just wanted to make sure that you have them to be able to sort of reference back of here's where we are in the process. So element 6, coordinating care. We have goal 1, which is providing coordinated integrated care in the community, with more details and materials that Lauren has shared and will be in Basecamp and also already are. But and then goal 2, providing coordinated integrated care across and within systems. So just a reminder of our sort of places where we are. And with that being said, I'm so excited to be able to turn this over. I don't know, Jerry or Wendell, who wants to start first, but I will let you guys duke it out. Thank you so much. We're so excited to have you here.
Okay, this is Wendell, and Jerry and I are actually presenting together in our district office conference room, and because we're brothers, sometimes we do sound alike, but I guess at that point it's not really important. But I guess to better illustrate a coordination of services between families, schools, and community, we're going to start with this mental model, and a mental model is just simply a picture of how something works or can work. So this mental model here is illustrates that students spend basically 14% of their waking time in school, all right? And so the reason why you look at this from a whole global standpoint is we look at it from when your community is not healthy and you have a high number of health disparities, like in our native community, it's childhood obesity, it's diabetes, asthma, sexually transmitted disease, teen pregnancy. And remember, all these have historical origins, but these origins walk through our schools every day, and kids wear them, and we as adults, we respond to them. So what we say is, schools, we have to be a place to be able to place our focus on intervention as well as prevention. But if you look at the part of the diagram where 86% of their waking and learning hours is primarily outside of school, okay? Which really means that the biggest influence is not going to be in that 14%, it's going to be in that 86%. And again, we're going to make an assumption that most kids sleep well. Not all kids sleep well. We're going to make an assumption most kids are in their homes well. They're not necessarily in stable homes. But what this does is it gives you a framework in which a coordination of care between families, schools, community, because we know that as stakeholders, we don't exist in a vacuum, and we can all help from each other. We can all help each other in order to do what's needed, and that comes about through these intersections. So, for instance, students don't learn if they're tired or they're hungry or if there are problems in the home or community. All right, and fortunately, schools, we're in that great position because of the critical mass. We have the kids. And if we use it to our advantage, it gives us an opportunity to provide links for our stakeholders to come together. And of course, in our our Menominee tribal community, we've gotten, we broke down those silos, and for the past 7 years, we've successfully coordinated our efforts in a number of areas, dental, nutrition, mental health, substance use, by using a theme of a culture of health. And that culture of health is healing the roots of some of that painful historical trauma and ACEs, and at the same time building hope and resilience in our families, our children, and in our community. So next slide. Yeah. Again, I think I would just, before we get to the next slide, I think we've all heard the saying that it takes a village, right? Well, in our Menominee Nation, and I think we can say in Indian country, we say, hey, it takes a res, right? So you can go to the next slide. So this here is how we respond to the challenges of those health determinants that were mentioned, and we do it through a tiered approach, although this here is a medicine wheel because it reflects more of our native culture. And so what we do is we can't just focus on the academics, all right? We've got more kids today, and it's not unique to Indian country, that are struggling in mental health, depression, anxiety, substance use, and again, poverty and ACEs. And what that does is it requires a different response. So what we do is, of course, we make a shift, and we educate and move to a paradigm shift we call educating the whole child, all right? And which means we look at all aspects of a child in terms of their physical well-being, their mental well-being, and their social well-being, all right? And what we do is we have this in a tiered system, and these are all based on the needs in our community. So you really got to know your community. So you can see that there's efforts in there that reflect around childhood obesity and diabetes, because we're talking about having healthy school meals. We're talking about making sure that we have time for physical activity, okay? You can see in there that with mental health, we do a lot of mindfulness and self-regulations in our schools, like our elementary school. They do mindfulness the very first thing when they come in the morning, all right? And if you get into the second tier, which is the early intervention, there's where we start drilling down a little more, and you can see that we've gotten away from the punitive approach of trying to teach kids through discipline by going towards more of a restorative practice, which to us has roots to indigenous communities, but it changes the accountability, where in traditional school discipline, it's usually an immediate consequence. Well, that doesn't work if you're emotional and you're stressed. So what we've done is the accountability piece is at the end, where we give kids time to process. We give kids time to regulate before we try to teach them the accountability piece. And that's been a big change for our teachers, especially, if a student has said something, pretty disrespectful. So we work with our teachers to help them understand that you can't take it personal. You've got to be able to let it roll off you, because those are words, and we can heal those words, okay? If you get into the yellow, which is our most severe or our intensive efforts, there's where we take the kids the students who are really struggling, and we have to get them counseling services. We have a student health center right on campus that we work collaboratively with our clinic and a few other agencies. And again, we're really trying to get at addressing this whole issue of attendance, because we don't look at attendance anymore through the eyes of truancy, which just means kids are not showing up and they're unexcused. We look at the whole piece of they're not there no matter what the reason. And it's when we started looking at the chronic absenteeism lens, it lined up more with our whole trauma-informed care efforts. So again, you can see this medicine wheel. I'm sure that in other Native communities, you might see some similarities, and it's possible you might see, you know, some differences, but that's a reflection here of what we're dealing with in our Menominee community. You can go to the next slide, please.
Okay, so I'm gonna give you a break here.
Yeah, thank you.
All right, he's all talked out now, so it's my turn. This is Jerry. And what we thought we wanted to share with you, anytime you talk about change, you know, leaders always ask for statistics, metrics. And what we wanted to show the group is some of the work we're doing, and realize it's taken us, you know, 7-8 years. I think the stats we're showing up are probably 6 and 7 years. So I think anytime you talk about a change framework, you know, you gotta show numbers. And unfortunately, through some of the work that Wendell had at the school, he got some partnerships going in the community, and we were one of them again. And I guess I've always said that I think education and health, it makes a lot of sense to be the cross-sector collaborative partners. But we just wanted to show you just some highlights of numbers, okay? So we're talking about not just schools, but if it's gonna work, it's gotta get to the community. And our numbers are good, we're happy, they can always be better, but if you could go to the next slide, maybe you can see another, some of the things we did to try to encourage participation is going to the tribal councils to get some support. And you can't just expect people to come. I mean, you know, we know people are busy, but until you get some champions from that tribal council, you know, things are gonna just take a little time. So, you know, we took that step, and boy, were we surprised, you know. So we kind of got a little bit more movement, and so it just continues to keep spreading. So
okay, and this is Wendell coming back. This connecting family, school, and community was an element, one of 5 elements that we received in a SAMHSA grant, in which when we received that money from SAMHSA in our state education department, what we basically said is, if we're going to do this right, we have to use that money not just in the schools, we got to use it with our community. And I think by being able to do that, we were able to build sustainability at the same time that we were implementing. And of course, what you see here is, you know, you can't move anything unless you've got the support of your leaders. And we were able to get our tribal council behind this, in which it took us almost 5, 6, 7 years in which we couldn't get them.
And I think the one thing we talk about is you got to have some resilience. So I know what the subject is tough. So you could go on to the next one. I think Wendell already, no, I think there's one more. Yeah, this probably just gets us more to the, you know, we've actually, if you look at the last bullet, you know, the point about sustainability, he's always stressed on me, we got to find partners, and you know, you want to find partners to keep the work going. So you know, we've got some in tribal administration, the clinic, and the school, I would say, are the 3 big partners that continue this effort going. So you know, that idea, if you're committed to it, then you're probably willing to put out some money to make sure the process works. So that's kind of how we're continuing to keep this effort going.
And if you could see where we started out when we first got the grant, you know, we had about 33 people showing up 4 times a year, where now we're well over 100 participants with over 41 different community programs and agencies, you know, coming together 4 times a year, writing 90-day cross-sector action plans, and not just sharing them, but I think what I would say is we're also holding each other accountable.
That's probably the bigger piece, is the accountability piece. So, okay, next slide. Is someone watching that time? I know we're supposed to, but Amelia, Lauren, we're okay? Yeah?
Doing great. We're about 2:15 right now, so doing
all right. Okay, so one of the things we've talked about, and you heard Wendell say, is, you know, the school and the clinic, and this is what we've done. We just figured if we showed a momentum model, you know, when you're a county like us, you're actually assessed a health ranking, and there's only 72 counties in Wisconsin, and we're at the bottom of the link, okay? And that's kind of our challenge. But the challenge to us is how could we work with the schools on some of the issues that we see. And what the first thing that really came up was kind of this dental clinic, and that thing worked so well that we've expanded it to 4 schools now in our community, and you're doing more of the prevention. I think right now we've staffed our dental clinic with a pediatric dentist, and to the point where some of the support staff will even bring the kids over to the clinic to get help or treatment, right?
And yeah, and this is Wendell. I just want to interject something. When we started the dental clinic, we were wanting to deal with the mental health and the abuse and neglect, but our community wasn't ready. So we took an area of working with kids around obesity and in school readiness. And so we went with the dental clinic because we knew that was probably a quick win that we could build collaboration on, where now we're dealing with the elephant in the room.
So the newest addition, we didn't change the slide though, is we're this fall, I think we're going to be adding optical services.
Yes.
Because you got to be able to see to learn too. So I think we've kind of got a good framework here, and looking forward to that. So I think that's kind of it for that slide, right? Okay. And so you can go to the next slide. So I think when I was sitting on the other side, I was thinking, well, okay, enough of that. Give me some examples, okay? So I thought we could take one in the one area we talk about is the kids who are, as Wendell said, are maybe not processing things, and we talk about maybe a little hyper. And I think what we found is, we have to be careful, thinking of the trauma that kids go through, So I think developing that partnerships with the teachers, working with some care coordinators at the clinic, but then also the behavioral health. So I just wanted to say those could be interjected at any part, from a family to the school, right? So those two are links. And I think what we just need to ensure is how are we doing this care coordination across the board. And sometimes you got to remember that just because the kid gets medicine, that doesn't mean they're going to get it. So
and I would even add, even if they get the medicine and they work with a therapist, if we don't take the lens and look at what were the conditions that this kid had prior to that, what was beyond their control versus, geez, they got a pill, they're seeing a psychotherapist, why are they not getting better?
Yeah.
You got to go back to really putting yourself in where these kids are coming from.
Right. So we just wanted to show that's one of the things. Now you can go to the next slide, and I'll show you a few more. And we've kind of used a process we call patient care. It's patient-centered care, and I don't know if I'm trying to think of all the partners out there. There might have been a few of the teams that were involved in it, but that really kind of switched our focus on patient-centered care versus any one department. And the thing that we're trying to work now is through this care coordination effort. So we basically funded 4 care coordinators. You can see we have basically there's 2, I think, in the medical department. We have 1 in community health, and then we have 1 over in I think behavioral health. So you see the need to try to do, if some of the people are familiar with medical home is more of a complete way to look at a patient versus just piecemealing it. And think of a diabetic who would maybe go to a diabetic educator and she needs to go see the dentist, or she needs to be over in behavioral health. There's these warm handoffs, there's things they do. But the other thing we've found is because of the problems in behavioral health that people don't, there's normally a waiting list though, so they don't want to wait 2 months. I need something now. So what we've tried to do in the medical clinic is do some brief interventions. And those of you who may know Diane, that's actually her job. She does the expert brief intervention, so she can do something right with the medical department and help on the intake. So we've done some things on our aging population with care coordination with our aging group. So that's the change that we've kind of developed here. And like Wendell said, we think it's a better delivery system, and you're probably going to have better outcomes. Now, like everything else, you have to use the metrics to evaluate it. So that's going to come to be pretty soon. But just to give you some example, those are those opportunities that we've seen to change our systems in the clinic, and then having a good partner with the schools. Anything else? If that's not it, we're waiting for that chat box to light up here. And Wendell, you got something?
No, I guess maybe if we could, I know whenever we work in our community engagement effort and we work with our consultant, whenever we do things like this, we always want to give people time to reflect. And maybe before we get into this roundtable discussion, that, you know, whether you're with a group or whether you're, even if you're by yourself, that you take a few minutes to reflect about, you know, what we were able to show. And again, we just gave you a snapshot, okay? Typically, when some of the Indian tribes across the country have come here, they spend anywhere from 2 to 4 days here learning from us.
That's great. So I'm just gonna jump in and say, you know, so we've had it's a lot to process, and thank you guys for the cue to actually give everybody a moment to sort of collect themselves and think about what kinds of questions they have, but also for each of the groups, and if we have a representative from each group who's able to talk, perhaps, you know, we just take a few minutes to sort of think about what questions or concerns or what are the things that your group is working on or struggling with. So I'm going to go ahead and just prompt, because I see this comment from Amanda Burns, who is the integrated behavioral health consultant at Oklahoma City Indian Clinic. And Amanda says, I'm able to do brief interventions and coordinate care between departments. But I want to invite you, Amanda, since you've been brave to already sort of put something in here. Do you want to jump in, and do you have questions or reflections or comments?
She's muted.
That's fine. So feel free to go ahead, and I'm just going to kind of go down the list here. Amruta may also not, but I'm going to just sort of go through our attendees list and sort of see who's got access to be able to jump in and talk. Amruta, do you have connection? That's okay. That's okay. So Amruta, you as well. Feel free to just use the chat box. In the meantime, I'm going to keep going down. What about Annika?
Hey, this is Marla from Gallup, and I have Janet, Adam, and Chantel here with me. Hi, everyone.
Oh, hi.
I think, I'm not sure if we can pose this as a question, but one of our biggest struggles with our working with the schools is that we are a border town to the Navajo Reservation. So a lot of the schools are, for lack of a better term, integrated, and we're trying to figure out how we present services as IHS to one population but not the other. It seems kind of weird, but we have been working with the school, the head school. Is she a counselor or psychiatrist?
Yeah. I think she's the head of counseling.
She's the head of counseling services, and we do see the need for our specific IHS population, but there's also a need for the non-IHS or the non-BEN population as well. So that's one of our kind of hang-ups. And I was just wondering if any of you present on the call have any suggestions or have any examples of how you work around working with Native populations and non-Native populations. Like how do you do it?
Marla, this is Julie from Copper River Native Association in Alaska. And we have an integrated school system up here. And one of the things that we have done is develop a partnership with the school district to actually embed. We have, I believe, 4 full-time employees up at the school. And sometimes they're working as, side paraprofessionals, and other times they're leading cultural activities. Sometimes they're assisting with gym class. All of this is coming, the root of this comes from our behavioral health department. And of course, primary care backs that up as we can with other parts and pieces, but we're just an ancillary, on the side of that, in support of what they're putting together. But our partnership is developed just out of a willingness to sit down and realize that what happens here affects their home life, affects how they perform in school, what their nutritional needs are. So we're even wrapping in our wellness department into this as we begin to discuss nutrition and diabetes prevention, that kind of thing. So it just took a few concerned people going to the school district and the development of a committee, and now we have an MOU with the school district, and like I said, 4 people embedded in the school that are paid by Copper River Native Association that come out of our behavioral health department.
This is Jerry.
2 of those are prevention techs.
Okay. So let me share with you some of the work that I think Menominee has done, and we didn't always have the door open, and I'm only saying that because I give Wendell a lot of credit. But the thing that we first did when we were trying to develop partnerships with the school is, as you say, put someone in the schools, and we concentrated on after-school activities. That was a great sell. So when you talked about your wellness program, I think you could get your foot in the door. We had a wellness person who was like a little kid. He just loved working with those kids, and that, I think, really kind of got us going, because he was getting them to move. And then from there, I think we developed a little bit further, but just the idea of playing dodgeball or doing something with a man, that guy had those kids going for about an hour after school. And then you kind of, as you say, passed it back to the school. But that was kind of our first baby steps that we took, and really kind of enhanced that we need to do more. And you're right, and I think we kind of took that soft approach. Behavioral health is just that. I always remember when I first started here, perceptions from parents was, just give me that magic pill and fix them. I'm not even going to come to the counseling. And I think we have to shift in that whole thinking of how we're going to help kids. But man, 10, 15 years ago, that's what some of the families would say. So you're starting, you're taking baby steps.
And kind of what Jerry, this is Wendell again, what he's alluding to is, when you say, how do you get your foot in the door? It's the same way that helps kids heal in trauma, is you got to develop relationships. And once we started developing relationships with our partners, well, then we started doing more. Well, then after that, we start sharing resources, not just people, but fiscal. So again, I think part of this is that, and I think it's so simple, but yet it's complex.
I think that actually, so that really nicely pairs both Amanda and Amruta, who are in Oklahoma City, are talking about, that there is a sovereign community school starting in Oklahoma City soon, and there is absolutely interest in building these relationships. But I think Janice puts it nicely here with this question of sort of, where do you start, and why does it seem so hard, that sort of initial relationship connection? What is it about schools and clinics that make it so hard? You have so much internal resistance to agencies working with schools.
I could share with you part of our journey is, of course, and go back to that 14%. And in that 14%, we have all these mandates from the state and from the feds about all the things that we got to get done, mainly academic. Well, when kids aren't doing well academically, and you start getting to the root causes, you've got to be able to say, you know, that academic piece is important, but we're not going to get to the academic piece if we're not making sure that our kids have proper nutrition, that they have support systems in the school. And we were able to show that to our leaders, in which now we still look at our achievement scores, but again, we know what we're dealing with. And I think that's a part of, how do you start something, is because, schools might say, well, it's kind of like, well, I gotta teach this whole book. Well, I think what we're saying is you might teach the main chapters of that book. And sometimes I think schools just need to hear from their leaders, I mean, you've got permission, because the needs of these kids are more important than they are a test score. I think our kids are more important than a test score.
We didn't come up with the word, but it's something that Robert Wood Johnson talks about, is the social determinants of health. I guess we'll pick on all these academic people. They understand that, but when we're in the trenches with kids just trying to be in survival mode, sometimes that perspective, you don't get that perspective. But you see a lot of kids who struggle with safety issues, housing issues, where their next meal is. And those are the ones that probably, unfortunately, have a lot of trauma in their life that we're trying to deal with. But I think that's the big picture we've seen, and that's kind of our goal, why we're working with Robert Wood Johnson on trying to continue on this journey and be ambassadors to health.
So you mentioned something very specific, which I think, everyone will have struggled with, which is test scores, right? So oftentimes teachers in schools even are frustrated with the arrangements of the way that standardized testing and everything that comes along with that fits into play. What have there been changes in the way you mentioned, sort of giving teachers permission? And I think that's such a huge thing, because everyone feels sort of stuck in these systems. What have you noticed in terms of changes in relationship to something as specific as that, like test scores? Have you noticed changes in the way they've approached it?
I think what I've seen, this is Wendell, is we look more at our growth. In other words, how are we improving over time? Mm-hmm. And I think when teachers are supported and they understand it's about growth, they're willing to take more chances, okay? They're willing to work out of the box. And I think that's how we look at our achievement data. So for instance, our on-time graduation rate is about a little over 80%. But if we stick with the kids a fifth year, well, that shoots up to about 85. And if they stay with us a sixth year, then we're hitting close to 88. And if there's a seventh year that they stay with us, we're hitting 95%.
Wow.
So let me give you another reflection, because remember, this is Jerry again. So we're gonna test you. If you got the voices down, that's pretty good. remember the slide I showed you on the ADHD? Okay, now think about it. That if you didn't have that relationship with the teacher, or the parent wasn't involved, what's going to happen? Your test scores are probably really going to struggle. But what happens when you get someone on the med and they can stay in that circle, they can stay in that room, and they're probably going to have better test results after a 6 month, 1 month. But that whole idea is that you're coordinating that work. So we'll have some of our therapists that will actually go over to the schools and see how the progress is going. And those of us who have families who are really engaged, and that's kind of completing the circle. And unfortunately, we do have a number of kids who are on ADHD, right? I mean, we'll be honest, maybe too many, but from the standpoint of, it seems to be a thing that's working and we can track it. And then at least you're kind of creating that sense of, okay, I got it, I can achieve, but just to see a kid's face when now that lens is switched now, and I'm getting good grades now,
and I think what this is, Wendell, when we say, okay, we've got a kid who's exhibiting ADHD behaviors, we're already going to make the switch that they more than likely have some kind of trauma in their lives. So we're not going to focus on the ADHD. We're going to look and say, well, what was their path? You know, what was that path from the time they were born to, you know, whether they were taken out of the home or when they entered into a detention center, something like that. But it really, once you're able to do that, you know, you do look at these kids differently.
That's such a good example.
All right.
What other, so let me see, we're hearing from Oklahoma City. What about other folks on the call? And here I'll let people know we're at about 2:37. So we've got another, you know, close to 10 minutes before we have to go. Anything from other sites or from others on our faculty? Diane, Susan, Janice, anybody else want to pop in?
Hi, can you hear me okay?
You sound great.
Yeah, thanks. I had the mic muted. And I appreciate the responses to the earlier questions. But I kind of want to go back to this a little bit because I think in the case of Menominee, there's a unique perspective because of Jerry and Wendell being brothers and one being head of the clinic and the other being head of the school. And so I doubt, though I could be wrong, that, you know, this would be the case in most communities. And it kind of harkens back to why I raised that question, because I think it is pretty challenging and it's very time consuming to begin to engage with schools because one is looking at school from a very academic perspective, lots of procedures that have to be followed. And the same is true from the clinical systems, the healthcare systems and behavioral health systems. And so, you know, I think that, you know, I don't want to minimize the complexity and why I was really wanting to hear from Wendell and Jerry and maybe Wendell more so that, you know, what's the starting point? And while I think the data is very useful to show, you know, that what dropout rates are looking like, what nutrition rates are looking like, how many kids are on, you know, free lunches and those kinds of services, and even what the clinical data is in terms of the number of patients on meds or being treated in the behavioral health system. But who do you take that to? How do you begin to really build those relationships? You know, do you walk in the school building and ask for the principal? You know, so I'm just wondering if you might just speak a little bit to that before we have to end the call.
Okay, I'm going to give it a quick shot. First of all, there's research out there about how health and education are interconnected. And I have some different citations that I've used because I do know that, you know, people say, yeah, it's easy because you and Jerry are brothers. Now, it makes it easier. But again, we started with something that was kind of simple. We were looking at our attendance data. And obviously our kids were not coming to school, and I didn't want to look at it from a truancy standpoint because that wasn't getting to the root cause. So in a conversation with Jerry, we were able to take looking at chronic absenteeism, looking at why kids don't show up for any particular reason, and then taking that to a healthcare and say, well, why don't people show up for their appointments? Because essentially it's the same thing. And to me, that, you know, if you can pull data around that, well, then you've got a common interest to discuss. I think what, you know, being a former principal, we're sitting in these buildings and we're struggling, and quite honestly, we're waiting for people to come in and say, how can I help? I know I'm not afraid to turn away help. And I certainly, with my principals, I tell them we don't turn away help. But I'm willing to bet that there is data that no matter whether you belong to healthcare, belong to schools, that you can say, can we have a conversation about it? We took the county health rankings from the Robert Wood Johnson, and they have these 24 areas in which you get ranked. Well, that was a health score. Well, what we did is we sat as a school team and we said, well, wait a minute. How do we contribute to these 24 determinants? Well, we found out we had a lot in common.
Yeah. Well, I certainly appreciate, your response, and I think that others on the call probably did too. I think that there's probably, Amelia, one last comment that you may want to have Jerry and Wendell address from Rhonda.
Yes.
Colville, yeah.
Yeah, so Rhonda from Colville mentioned, and I'm going to just read this for anybody who's on the phone. She said, at our last meeting, our councilwoman noticed several children graduated from Head Start, but very few graduated from high school. We have 4 large communities on the Colville Indian Reservation, and I think some of our leaders should visit your reservation.
We would welcome that opportunity.
So here's my first question. Does your school have a partnership with Head Start? We do, and what we've done is in our trauma-informed care efforts, what we do in Head Start is the exact same thing we're doing in our 4-year-old and 5-year-old kindergarten program. Because we want to make sure that, because we know at grade 3, the change goes from learning to read to reading to learn. So we're trying to make sure that we're getting as many kids ready for that 3rd grade test of where their reading score is at. But in order to do that, that's why we're in the Head Start. But this really is not going to take off until we're in talking to whether it's prenatal care or talking to the families. But again, as Jerry mentioned, we're always happy to share what we're doing here. We don't feel that we have all the answers. We do have something that's showing continuous improvement.
I think one of the slides we've talked about is, we got to start connecting some dots, okay? And I think for too many years, we've been out there fighting our own battles. Now we got to start developing these partnerships. And it just so happened that we decided to do the schools. Now, let me tell you, being brothers isn't always the greatest thing when you live in the same community, So, Janice, just be careful how you said that. I mean, then it's the Indian jealousy. It's, why you guys and why that? And it's like, all right, we can look through that. But we've been pretty resilient because, our elders taught us that if your heart's in it, you're probably going to be doing the right things, And I think what we talk about is having passion for what we're trying to do, it's something that I guess is instilled in us. We want to make this better than what we left it, and then give it the challenge to someone else. So.
Well said, my friend. And I was only pointing that out because I think it is to be celebrated and it's unique. And I'm glad that that you have the relationships that you have there. But I don't know that they exist in quite the same way in other places. And it was just a wonderful opportunity to be able to have both of you on the call, and also to have you, help us think through how, other sites can do this work, can improve this work, can expand this work. So, we really appreciate it, Wendell and Jerry.
Okay, thank you.
Thank you.
So we're at time. So I just wanted to really quickly say a couple of things. Thanks to everyone for coming. We'll be posting the recording of this along with the chat to Basecamp. Please, while things are fresh, I know everybody's going to have to run to other things, but if you have thoughts in the next day or two or any time along, please let's continue the conversation on Basecamp because I suspect for many people, this is just the beginning of really getting into sort of the questions and challenges. Just quick reminders that Learning Session 2 is coming up from Monday to Wednesday of August 5th through 7th. And today, if you had any issues accessing on GoToMeetings or struggling with Basecamp, metrics, anything at all, please feel free to get in touch with me. And we'll go ahead and bring things to a formal close. If anybody wants to stick around for questions, I'll keep the room open for a few more minutes. Thanks to everyone, and thank you, Jerry and Wendell, so much for a wonderful presentation.
Okay, you're welcome.
Thank you.
Jerry and Wendell.
Thank you. Bye-bye.
Bye.
Bye, thank you.
All right. Well, we did our lead in time.
All right, guys, you got to be super busy. Head back to what you've been doing. Thank you so much.